Hello, everybody. Welcome to this episode of Pharmacy Pathways. I have here my good friend, Dr. Alana Rice. We went through pharmacy school together and we're still
Yeah.
getting together for our girls' trips after school. And she was so kind to come on here and talk about what she does because she has a very cool job. Y'all know that I love highlighting the niche areas. She is a gastroenterology pharmacist and she does this remotely. So I have lots of questions for her because I need her to spill the beans about all the cool stuff that she gets to do and how she's able to do this from the comfort of her home. So without further ado, I introduce to you Dr. Alana Rice.
Hello, how are you guys? Woot woot.
They said they're doing great. Uh, so Elena, if you could, give us a little bit more information about your background and your current role in pharmacy.
Okay. So I'm from Flint, Michigan, small town or smallish town, and I graduated 2013 and then went to UNC for undergrad. Did 3 years of undergrad and then applied to their pharmacy school, got in, and so went to UNC Eshelman School of Pharmacy from 2016 to 2020, where I met Dom. And we were clicked up. Our group was tight, and we're still tight to this day, as she mentioned. Post graduation, which was probably the worst time to graduate into the pandemic, but we made it through. I did my PGY1 at the Michael E. DeBakey Houston VA Medical Center in Houston, Texas. Um, at first, I thought I wanted to do like an infectious disease PGY2. I was interested in like specializing in HIV. However, quickly learned that ID was not for me and decided I want to pursue ambulatory care because I love like building that relationship with patients. But I kind of made the decision too late to stay on at the Houston VA, which I think was actually better for me. And I went on to do a PGY2 at the University of Kansas Health System in the ambulatory care program, where I learned about all these different specialty disease states, including cystic fibrosis, of course, HIV, because that was my passion at the time, dermatology, women's health and fertility, rheumatology, and then, of course, gastroenterology. And so, from my experience at the University of Kansas, I was able to find a job actually back in Houston or a little south of Houston at the University of Texas Medical Branch, where I was the gastroenterologist and started clinical service in that clinic for 2.5 years before I left UTMB and went to Yale Health, first as a multi-specialty pharmacist, and then now as a rheumatology and digestive health pharmacist.
Yes, so you're right, because I didn't mention that you also cover rheumatology, which is another
Hmm.
niche area to practice because we maybe get like one or two classes on that. It's something that we study for. I believe it was in the NAPLEX. Um,
We
I
might have had one class about it. I remember a class about multiple sclerosis more than I remember any class about like GI or rheum diseases.
Yeah, same. So when I hear about pharmacists practicing in areas that we didn't really get much, focus in our curriculum, I love to hear like how they got exposed to that. For you, that was your residency program.
Hmm. It was. I specifically looked for residency programs that had more than just primary care. When I graduated PGY1, I don't think I was perfect, or I don't think I could have like immediately been comfortable managing primary care, but I didn't think I needed a full year to feel that comfortable. So if I was going to dedicate another year to do residency, I wanted to explore disease states that we weren't like taught from the time we get into pharmacy school to the time we leave. So I was
Yeah.
kind of tired of diabetes, hypertension, hyperlipidemia, and wanted to see something else. And so I looked for AmCare residencies that had other specialties, which included Kansas, which I wouldn't have thought of going to from the state alone, but the program was just, it sounded amazing. And so I do highly recommend it if anybody's interested.
Yes, and we're not, we got to make a disclaimer. Nothing's wrong with Kansas, the state.
Nothing's wrong with the state. It just, When I thought of Kansas, I was thinking of the Wizard of Oz, and I said, I'm not Dorothy.
You know what? Okay. And also, you came from my favorite disease states. I love diabetes, hypertension, and
I
hyperlipidemia.
understand it's our bread and butter. Everybody loves it. It's a great disease state. I just got tired of it.
Oh, I understand. I understand. You wanted something fresh.
Yes, something new, something challenging.
Yes. So, with that being said, like, what was the moment that you were like, you know what, I really like this. I think that I could see myself practicing this. Like, what was that moment for you? Or maybe if it wasn't like one singular moment, like the little things that led up to you really taking an interest.
So obviously when I went to PGY2, we wanted to do HIV. They kind of told me like, we don't think we're going to have a spot for HIV. So like, whatever. But then when I started, I think my first specialty rotation was technically like gastroenterology. And so learning about the biologics, I was like, oh, this is like new. This is different. I haven't heard really learned about this stuff in school. And so my interest was piqued. And then obviously when you do rheumatology and dermatology, a lot of the drugs do overlap. And so
Hmm.
I got more comfortable with it so that by time I was finishing up my residency, I was like, okay, I can look for a job. And I think I would want to do one of these disease states if I can't find one in HIV. And so when I was applying to UTMB, I think they said they had GI, rheumatology, and neurology as position options. I knew I didn't want neurology. Epilepsy was not my
That
forte.
that's fair.
I am traumatized from the classes that we had where we learned about epilepsy and how they taught us. I was just like, no, I never want to do that ever again. And so she offered me GI because I think they had spoke to that clinic first. And so I was like, okay, I can do it. I didn't feel like, yay, hoo about it.
Yeah.
But it was just like, I feel comfortable doing it and I can start doing it. And so
Okay.
I get into the clinic and really what really just made me excited about it and why I was excited to take on this position at Yale and continue to do GI at Yale was just because of the patient relations that I built and like how I was able to help them and how well like these medications really improve their disease state. Like I think when I first started, they were in the process of like approving several different medications. And like a little, I guess maybe 2015, 2010, they may only had like three treatment options. And by now they have like closer to 10 treatment options. And just having that expansion of treatment options and seeing how well they work and change patients' lives just really excited me. And like hearing my patient's story about like what they went through and like how this medication has changed their lives, I was like, this is where I'm supposed to be.
That's huge. 3 versus 10 may not sound like a lot, but when it comes to autoimmune options, that is huge.
Especially like with the medical discoveries, it's kind of like similar to HIV, where like we just had that one treatment option, and now we have so many treatment options, and we basically can almost cure patients. It's kind of similar to that.
We have like the golden standard pathway:
Hmm.
graduate, go get a residency at PGY1. If you're specializing, get a PGY2, and then you apply,
Hmm.
which is, technically what you did. You did the golden standard, but I know that you know people who still work in your field that didn't take that route. So,
Yes.
what are other ways that people have gotten into this space?
Yeah, I think it's just kind of like by happenstance, they just find a job and they're interested in learning something new. Like one of my old coworkers at my old job, he went on to become the rheumatology pharmacist at UTMB and was just very excited. And you kind of just have to have a eagerness to learn or willingness to learn. Um, and as long as you're willing to learn a new disease state, you really can just do it from any job. At my current position, I know there's some pharmacists that were like crit care or like in the ICU inpatient side, and then they transitioned to AM care and digestive health. There was one that was like maybe emergency med, the ED pharmacist
Mm-hmm.
and wanted to change maybe a slower pace than the ED and wanted to move into AM care and the position was open and she was willing to learn about the new disease state I think there may have been some internal medicine pharmacists. A lot of inpatient people in my job transitioned to the AmCare digestive health space. And so just having that willingness to learn a
Hmm.
new disease state, even if you're not familiar with the drugs, if you're not familiar with the disease state, just being able to learn, being open to learn is a
Hmm.
great way to just get the position, and just knowing somebody or speaking with the managers there. I think it was easier for them at my current job because they already worked at Yale, and so just transitioning to a different state or different area of practice.
And when they're learning these new conditions, or I guess honing in on them, like when I hear about the ED or ICU, you're like fixing the issue in that moment.
Hmm.
You're not really responsible for what happens next.
Yeah,
You're just stopping the acute issue, but now they're transitioning to roles where they have to be the person who is following up and involved in
preventing
the
these acute
maintenance.
issues.
Yeah. And the disease states now that they're seeing are not as vast.
Hmm.
And if you can expand on like all that encompasses with gastroenterology, because we just think of the stomach, but
Hmm.
you do more than that. You do more organ systems than that.
Yes.
And then also rheumatology and how many organ systems you might have to be familiar with that as well.
Yeah. So with GI, gastroenterology, it's I focus on the disease states, inflammatory bowel disease, and then at my old job, I also was working with hepatitis C, and some hepatitis B patients. So it includes your stomach, technically your whole GI tract, which they say, and I hope I'm okay to say this, mouth to anus is what we say for the GI tract. So it can affect anywhere from mouth, any ulcers in your mouth, all the way to your anus, which is an organ system or an organ. So that includes your esophagus, that does include your stomach, your intestines, your liver. I didn't specifically deal with it frequently, but it can include your pancreas. And then with rheumatology, it's mainly your joints. So like your fingers, your hand, your wrist, your knees, even your neck and shoulders can be affected. And this could be like rheumatoid arthritis, which is the major one that like normally affects the joints. Psoriatic arthritis, which can be associated with psoriasis. They have like sclerosing disease, which can affect interconnective tissues. They can have issues with the eye. We see a lot of uveitis patients. So I'm new to rheumatology. I'm just trying to think of the disease states I'm most frequently seeing, and lupus is the other one,
Mm,
which can affect multiple parts of your body, like your skin. It can affect your kidneys. It can affect your muscular system. So
mhm.
those are usually the main disease states I'm seeing right now with rheumatology.
That's a
Yes.
lot of organ systems that you have to be
Yes.
familiar with. And you already said biologics is the drug
Hmm.
class that you're working with most frequently. So for those who are watching who aren't as familiar with the biologic drug class, like what is so nuanced about them? Why might they be, a drug class that people enjoy working with, and why might they be a headache for others? I feel like I feel like they're one and the same. It depends on the person and what
Yeah, it can be. Starting with the, I guess, negative first, the biggest problem with working with biologics is just like the cost and dealing with insurance, which, I mean, I guess technically we can deal with that with any of the disease states or any of the medications, but because biologics are they're monoclonal antibodies, so it's a very large protein and it requires like certain lab conditions to make. It's just like it's not super simple to make. Like Losartan versus a biologic may take several hours to several days to create. The insurance is the biggest thing because they're super expensive. A lot of them are like starting out at 10 to 30,000 per dose. And if you have to do this dose, some of them are every 2 weeks. Some of them are less frequent, like every 8 weeks. That's a lot of money for insurance. So like getting them to approve for it and pay for it is a big headache. What I like about biologics specifically is just I think how they work with the immune system to kind of reduce the inflammation in the body. So that they're specific to certain parts of the immune system. So biologics may be the bigger picture, but like even under biologics, there are different classes. Like you have the TNF inhibitors, which is tumor necrosis factor inhibitors. You have your interleukin 12s, your interleukin 23s, your interleukin 6 and 17s, that all target different parts of the immune system to kind of dampen down on the inflammation that may be causing some of these disease states. Unfortunately, we don't always know, like, say I have Crohn's disease. They can't like look at me. They can't do any tests to say that it's interleukin 17 or technically not even that one. It's interleukin 23 that's causing your inflammation. And so sometimes you do have to go through some trial and errors to figure
Yeah.
out what the correct medication is for the patient. I know when I was in residency, for rheumatology, there was a test that they could use to see if a TNF inhibitor would be appropriate to treat. Haven't seen it like be used in the real world so far, so I don't know how successful the test is or how widespread it is. But even just like the thought of like maybe one day we can do like the personalized medicine where we do some type of genome testing on you to figure out, okay, it's this specific target that's causing these issues so
Yeah.
that we can pick and choose the right medications for you. So I kind of like it because it's not like very cut and dry.
Hmm.
Like with your hypertension, we know we usually start with a ACE inhibitor or an ARB, but with Crohn's disease and rheumatoid arthritis and these GI and rheumatology diseases, the guidelines are kind of just like you can use any of them, but they don't really say like this is what you should use first and this is what you should use second. It's just like, okay, these are all approved for it. I think the JAK inhibitors are technically approved second line for Crohn's disease and ulcerative colitis, but when you see them work as first line, they work just as great, if not better, than another first line agent. So,
To your point, like the cost is a huge barrier for
mhm,
people and also a headache for the people who are trying to treat the people. Um, but biosimilars now are coming out pretty frequently, I believe.
mhm.
I'm seeing them even on where I stand when I'm even looking at general like transition to care reviews and what is that looking like now in the space? Do you find that the biosimilars are working just as well for your patients, and is that making it more accessible for them to get the healthcare they need?
So biosimilars, just in case anybody doesn't know, are kind of like generic versions of biologics. That's basically what I tell patients. Like I mentioned before, biologics are monoclonal antibodies, so these huge protein organisms, and so it's very hard to replicate exactly the same like protein chain. And so there'll be like small differences in the protein chains that are not significant enough to like affect the efficacy or the safety. So like the main protein that makes it Humira is the same, but like maybe this one little protein way down the chain might be alanine versus I forgot what the other protein was, lysine or something
Yeah,
like
there
that.
we go.
Something insignificant. And so I haven't really seen a cost difference for the patient itself. You're probably gonna get mad at me again. It really just saves the insurance's money versus really saving the patient's money. Just because a lot of these medications do have copay cards provided by the manufacturer. So as long as they have a commercial insurance, um, no matter if you get Humira versus like Hyrimoz or Sotezo, there's a copay card that will bring it down to like $0 to $15. So a lot of times the patients aren't paying too much even for the um, reference product of the biologic. And so it's a lot of cost saving on the behind the scenes. Of course, if a patient maybe has like Medicare, they might see a price difference with Humira versus one of the biosimilars of Humira, but I haven't really seen much of a difference.
Hmm.
What I'm concerned about with biosimilars is that there's not a lot of data currently that shows that it's okay to switch between different biosimilars. And so what I'm worried about, because it is kind of like a contract between the manufacturer and the insurance, what if one year Say this year, your insurance has a contract with the manufacturer of Humira. You get Humira for pretty cheap. Next year, they have it with a contract with the manufacturer of the biosimilar Hyrimoz. Okay, so now you're on Hyrimoz. Then the year after that, they change it to a different biosimilar. And so I
Hmm.
don't know if that's going to happen just because it is pretty new, at least on the prescription side. We had biosimilars for Remicade, which is an infusion, for a while now. And that one usually has, from my experience, stayed the same. Like I see the patients stay on the same biosimilar product for several years. Um, but I know sometimes on the pharmacy benefit side, we can see changes in contracts a lot more frequently. And so that is something that I'm worried about because we don't have a lot of data to suggest that
It's safe.
multiple switches from biosimilars are safe. Although in theory it should be because, like I said, should be the same efficacy, should be the same side effect profile. But we just don't know, and that makes me a little bit concerned.
And to piggyback off of the complexity of biologics and biosimilars compared to the standard brands and generic medications, to your point, in order to treat autoimmune disorders, you are silencing their natural immune system, right? And so that puts them at risk of side effects happening. Are you also managing a lot of side effects that might be resulting as, toning down someone's natural immune system?
Yeah, I wouldn't say silencing, maybe just like lowering the volume a little bit.
Okay.
Silencing is like zero. You put
You're
the
right.
TV on zero versus lowering the volume might go from 20 to 18 or 17.
You're right. Okay.
So it depends on the medication. Like there's some biologics that are more immune system depleting than others, like the TNF alphas. And I'm referencing a lot of medications that are more specific to GI just because I've been in that area longer. So like the TNF inhibitors are the strongest class in the Crohn's disease, inflammatory bowel disease area. And then you have like the newer medications like the interleukins 12 and 23s, and those are more specific. So when you compare the infection risk between like a TNF inhibitor versus an IL-12 or 23, or even an anti-interleukin or anti-integrin, I'm sorry, the immune suppression is a lot less, so
Mm-hmm.
the infection risk is lower. So with the anti-integrin, that one is very gut specific. And so, yes, there's still technically a chance for them to, or a chance for the medication to work on other parts of the body, but it's usually most of it, like 90% of it's going to the gut. And so we kind of say like you're not as immunosuppressed compared to some that if you're on a TNF inhibitor. And that's similar to the interleukin 12 and 23s. They're a little bit more immunosuppressing than the anti-integrin, but not as much as the TNF inhibitors. But for all of the medications, it's not like patients have to become bubble boys. Recommend staying up to date on your vaccines. Uh, I recommend wearing a mask around sick people or in large crowds, just as like good protection from respiratory infections. Maintaining good hand hygiene. And then we do test for two specific infections, tuberculosis, that one's annually. And then the other one is hepatitis B. That one's usually like baseline, and you can do it like every 5 or so years if you want, but not really necessary unless the patient's at risk.
Excuse me. I hope you don't mind if I cut in for a moment.
Hurry up.
Number one, thank you for watching. I hope you're learning something new in this episode. Number two, which is the reason I'm here, is if you don't mind, could you be so kind and like this video or hit the subscribe button?
I mean, I've always subscribed.
By subscribing, you're letting YouTube know that my content is providing you value, and that ultimately helps the channel grow and reach more people who need to hear these conversations. You can also subscribe to the Pharmacy Pathways newsletter to get access to exclusive episode content. Newsletters go out in the same week of the episode. You'll receive a structured summary of each interview, expanded guest bios, and exclusive sneak peeks of future episodes. Subscribe at pharmacypathways.org. Link is in the description. Oh, and one more thing.
Hurry up!
If there's a specific topic or career you'd like to see featured, you can let me know by filling out the audience feedback survey on my website. And if you'd like to be a guest, there's a guest sign-up form on my website as well. Both of those links are in the episode description. Okay, let's get you back to the show. Okay, so you're responsible also for knowing the different vaccines and the schedules of the vaccines that they need to get?
The shingles vaccine, hepatitis B, we recommend if you're not immune, hepatitis A, the new pneumonia vaccines, there's Prevnar 20, there's Prevnar 15, I think there's Prevnar 21. Usually I have a reference sheet and I'm not like just saying this stuff off the top of my head.
So you're responsible for knowing the organ systems. You're responsible for having a general understanding of what's going on in the body, even though we don't have really the very specific testing that we would like in order to identify like what is actually causing the issue at that time. And then vaccines. What else are you doing in your day-to-day role? Like, where do you fall in with the multidisciplinary team?
Yeah. So I can give you two examples. One in my current role, which is like completely remote, and one where at my old job where it was like kind of a hybrid position. So for the hybrid provision, I would work with the providers. They had one half day a week where they would only see like inflammatory bowel disease patients. And so on those days, I was in the team room with the patients. It was kind of a lot because I was bouncing between two providers, and one provider would have like 18 patients, and the other provider would have like 10 patients. And I had to work them all up and know like what was going on with them and if they were going to start a new medication, that type of stuff. And so because I worked every patient up, I had an idea, because I knew the disease state. So like you can read the notes and like, okay, if their recent colonoscopy was showing moderate severe disease and they're not on something, we're probably going to need something. If a patient has recently called in and saying like, I'm flaring, I'm having 10 bowel movements per day, they're all bloody, they're all diarrhea. Okay, something needs to change. We probably have to put you on a new medication. So you can read the notes and like read any like patient calls to get an idea who may need a new medication or who may need to adjust their medication. So like I would make a mark or a note to myself, like, okay, I might need to go in with these patients or talk to the doctor about these patients. And so I would kind of just listen into what they were talking about whenever they were discussing the patients. That they were like, oh, let's switch medications. That's when I would kind of pop in and be like, okay, well, what do you want to do? And depending on the patient and like it also changed from when I first started versus when I left that position. When I first started, it was more like, okay, doctor wants to start XYZ. I'm just going to go in there and counsel. After a while, and after I built my like rapport with them, they'd be like, okay, let's start XYZ. And I'd be like, maybe we should try ABC instead because da 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 da. And sometimes they'd be like, okay. Other times they'd be like, please get away from me. And so they like called me because like I said, there was a lot of new developments in inflammatory bowel disease in the last few years. And so when I first started working, my doctors were more used to the old ones that we had, and they
Mhm.
weren't really using the new medication. So I was just like, let's try to see what this new medication is doing because it's better to know like on somebody who maybe is not as severe versus somebody's in the hospital and you're like, should I try this new medication or should I take out their colon? If you
Mm.
have some history with these new medications, maybe will prevent them from ever having like being hospitalized where they need to lose their colon in the first place. And so when I was first trying to like nudge them about these new medications, they'd be like, are you like, they asked me if I worked for the pharma companies because they were like, why are you pushing this drug? And I'm like, I just want you guys to try. Let's see how it works in our patient. Like maybe these are really good medications for our patient population and we're just not taking advantage of it. And we're kind of treating them with less effective medications. So eventually they got to the point where they were like, okay, they started using them. They saw how they worked. They were like, oh, okay, I like these medications. And so then they would start coming to me like, let's get them started on XYZ. And I said, yes. My proudest moment before I left, one of my doctors was like, should we do dual therapy? So two biologics. And I said, I've been waiting on this day for the longest because back at Kansas, the doctors were doing dual therapy a lot. And I was like, oh, I mean, obviously you increase the risk of like the immunosuppression, but there are some patients where it's like they only get partial response from every medication. So if you have two partial response, maybe you'll get a full response. And so I was like, I never asked him about dual therapy because I was like, I just got them doing the new medications. So when he came to me about the dual therapy, I was like, oh yeah, let's do it. And I got it approved. And I did ask some of my old coworkers because I had left by the time she had started therapy. And I was like, how's she doing? And they were like, one of her inflammatory markers had like become normal, which never happened for that patient. And I said,
Wow.
oh. great things for that. But by being in the clinic, I was able to connect, like have those conversations with the doctor as they decided to make those decisions. And then I would go into the patient room and counsel them on the medication and like tell them all about the medication and tell them about the process of how we'll get it approved. So if it was an infusion medication, we'll have to go through either our infusion center or if you have a preferred infusion center through them. If it was a pharmacy, like a prescription, we sent it to our pharmacy to do the prior authorization. And then once it was approved, either whatever pharmacy or insurance preferred, or we could fill it at our pharmacy. And then I would do follow up with them. Sometimes the follow up would be on the phone, depending on like how frequently I followed up, or if they weren't like some of our patients like lived 2 or 3 hours away, so it was harder for them
Mm,
to come in for appointments. So if they couldn't get into an appointment maybe like once or twice a year, I was on the phone calling them to check in with them, seeing how their symptoms were doing. Like, have you went from 10 bowel movements to maybe 1 or 2 per day? Are you having blood still in your stools? That type of stuff.
mhm,
Obviously assessing for side effects. Are you having those infections? Are you having like headache and tiredness or acne or something like that? Making sure that they can still get their medication. Like have to do a prior auth every year. Sometimes your insurance mess up or they lose insurance or change insurance. So making sure that they're still able to get their medication and not having issues with that. And then making sure that they were on top of labs. And then some patients I would also make sure like, okay, it's been 8, 9 months since you last saw the doctor, unfortunately, or not unfortunately, but like you do have to come in at least once a year per insurance to
mhm.
continue to get this medication. So I would make sure that they would come in to see the doctor. Versus now it's completely remote. And so I'm not as involved in at least from my experience so far. And
Mhm.
I'm still kind of building with my rapport with my providers, and maybe it'll be different after a while. But a lot of times they already have a decision that they make. They'll send me like a message and say like, "Hey, I want to start patient on XYZ," and I will call the patient or set up a schedule for the patient, call them, counsel them on the medication, order the med, make sure that their labs are like all done or up to date, and then send the prescription again, like the infusion center or to our pharmacy to do the prior authorization and then send it out to wherever it needs to go. Um, so the main thing is like the main difference is not as much integration with the team or like team decision
Yeah.
and not as much like face to face time with the patients. So I'm not sure if it makes as much of a difference because I did speak to a lot of patients over the phone in my old job and we still had great relations.
Other skill sets that I'm picking up on is you need to be able to read and interpret labs.
hmm
What kind of lab work do you care about specifically?
So of course, like your CBC complete blood count, you want to make sure like their lymphocytes aren't dropping. There are some medications where that may be more of a concern, or with the TNF inhibitors and I believe the JAK inhibitors as well. There's a malignancy risk which is associated with lymphoma. So you want to monitor the CBC to, if you start seeing some blood count issues, okay, is this lymphoma? Let's work it up before it becomes stage 4. Of course, you want to do like, I guess you really don't need the hepatic bunching test, but I just do a CMP, complete metabolic panel. A lot of things affect your liver. Some of the medications may affect your liver, so we monitor those lab levels. Tuberculosis annually. Um, for GI specifically, there's 2 inflammatory tests that we do, the C-reactive protein or CRP, which is a little bit non-specific, but it is just a blood test. And then the other one is the fecal calprotectin, which is a stool test. So sometimes we can only get the CRP because patients are like, they got to take a stool kit home, defecate in the stool kit, bring the stool kit back. It's a lot. So a lot of patients may not be able to complete that as quickly, or it takes them a while, or I don't know, they just don't want to do it. So we don't always have a fecal calprotectin. Your hepatitis B serology, so hepatitis B surface antibody, surface antigen, and core antibody. You want to see if they have a previous history of hepatitis B or any immunity. Um, for some of the medications, you need to know MMR and varicella immunity. Some of them require pre-vaccination with that. And then lipid panel for one class of medication.
Are gastroenterologists, pharmacists usually in a hospital setting, or are they more in a clinic, outpatient focused setting?
I've only seen them in clinic settings. I have not heard of a pharmacist specific to GI in the inpatient setting. Of course, like if somebody is admitted to the hospital for like a Crohn's or ulcerative colitis flare, I would think they would be on like an internal medicine floor. So like an internal medicine pharmacist may need to know like a little bit about the drugs, but like they're not truly managing. And a lot of times when you're inpatient to manage flares, it's a lot of steroid use and it may require surgery. So I don't think the pharmacists on the inpatient side really have to know the medications or be as super familiar. So it's usually like the clinic-based settings that you'll see gastroenterology and rheumatology pharmacists in.
Mm. And have you noticed a difference in work-life balance when you're working remotely versus when you're in the actual clinic?
No, not for me specifically. Like clinic is usually just about everywhere, kind of like a 8 to 4 time frame. So like I might get there a little bit, or like when I was working in person, I may get to work like at 7:30 just to get myself together, and might leave a little bit after 4 just to make sure all my notes are done, or like I don't have any like labs or anything lingering. Although like with outpatient, usually if things are that serious, we do recommend you go to the emergency room. Like we didn't have walk-in services. So like if you call me Friday at 4 o'clock talking about like I'm having a flare, I'm just gonna be like, we can't see you to Monday. So if it's really severe, please go to the emergency room.
Mm-hmm. And at least calm down the flare until they can come see
Yeah.
you. Okay.
Yeah. They can get
And
like a little prednisone taper or something.
yeah, and you were sharing with me offline that being at home, you kind of can orchestrate your schedule to even put like a time block aside for those patients who need emergency appointments.
Hmm.
So can you speak a little bit about that and how you have your schedule set up?
Yeah. So at my current job, we actually have a patient panel versus at my old job, I was just kind of cold calling patients. Like I would tell them like, gonna call you in, sorry, 6 months or something.
Mm-hmm.
I didn't like have them on a schedule or like they didn't know when I was a call. Like there wasn't anything that they can check in their medical records to say like, oh, Elena's gonna call me on this day at this time. So a lot of it was a little bit of cold calling. Versus now I have a patient panel. So whenever I speak with, well, to even first or for me to even speak to them the first time, one of our technicians will call them to get them on my schedule. And then for follow-ups, I'll be like, okay, I am going to follow with you in X amount of weeks or X amount of months. Would this day at this time work for you? And they would have to agree with it, and then we would sign it up. So I am able to block parts of my schedule for urgent visits, and so I will do one urgent visit per block. So you have your AM, which is like 8 to 11, 11:30, and then your PM block, which would be like 1 to 4. I have a block for 30 minutes for an urgent patient. If
Okay.
somebody's calling in, they're like, hey, I'm not really doing well. Can I talk to the pharmacist?
Mm-hmm.
They can be scheduled on my urgent visits, especially if I have a packed day. I'm like, okay, well, I have this visit set aside for urgent visits. You can be seen then.
Are your patient encounter durations typically 30 minutes?
Usually for the initial visit, we'll do like 60 minutes just because patients may have a lot of questions or, you gotta go into details about the medication and make sure that they feel comfortable and are aware about what medication they're taking. We'll do 60 minutes and then the follow-up visits are usually 30 minutes. Usually just because pretty quick. You're just kind of touching base to see how things are going. And unless the patient's doing bad, you don't really need that much extra time.
Okay.
But it just kind of varies per person.
And usually, if they're doing bad, you're going to hear from them before your appointment.
No, some patients wait till you call them and be like, yeah, for the past 3 months, I've been like suffering. And you'd be like, well, why didn't you say anything. And they were like, well, we didn't want to bother you, but you're suffering. So like, that's what we're here for.
Oh, wow.
I can help now, but you really should have said something sooner. I think that's a little bit different between like your GI patients and your rheumatology patients. Like your GI patients are more likely to say something because that kind of does affect them. Like I've had patients before they started medication, I can't leave my house because every X amount of minutes I need to be on the toilet.
Mm-hmm.
And so that can really affect their life versus with the rheumatology patients, since it's like related to your joint. I mean, joint pain, not to say that that's easy to deal with, but people can deal with pain better or like, they're like, okay, I've always been in pain. So like, yeah, I'm in a little bit more pain, but it is what it is. It's just pain.
Yeah.
Like I live with pain. So I'm kind of used to it. So it's not as severe to them.
It's
Even though
not
when
a,
they talk to me, I'm like, oh my God, like we need to do something.
yeah. It's not as intrusive to their
Hmm.
quality of life.
Yeah.
Oh,
They
man.
suffer at work. Like
Mm.
it can be bad.
Okay, so you are on the lookout for these things. You're monitoring. And did you mention that you ordered the medications?
Hmm. So at my old job, again, it was kind of I built a relationship with the providers. Um, because and we worked with a lot of fellows and learners. So like they would place orders and I would have to kind of nudge them and be like, hey, that was ordered incorrectly. Let me show you how to order this. And so after a while, they kind of were just like, okay, well, you know how to order this correctly, so you just do it. And so like, I mean, obviously I wasn't just ordering willy nilly. The doctor would be like, let's start this, or we would agree about them starting this or changing
Hmm.
the dosing to this. And I would just put the orders in because sometimes if they would put the orders in, we may be going back and forth a while because of some slight mistakes.
So
And
are you under a collaborative practice agreement?
I was under one at my previous job, but it was more general. We were just starting clinical services on the AMP care side. So like each clinic looked a little bit different. Um, and like what each provider would let you do would be a bit different. So like my IBD providers, by the time I left, I mean, obviously I was never just ordering medications willy nilly, but like the labs, I would just place the orders for the labs. Or like a patient would call me and be like, I'm having all these symptoms. I'd be like, okay. I would call the doctor just to see if they wanted something else, but I'd be like, we're going to get a CBC, we're going to get a CMP, we're going to need a stool sample, we're going to need a CRP. Your TB is due, so let me just order all of this. And I would just be like, hey, I've ordered this. Is there anything else you want to order? And
Mm-hmm.
so because I learned my provider so well that I knew what they were going to ask for, that we didn't need to waste time going back and forth between that. And
Yeah.
so then it would be like, if you wanted to do something special, like maybe a patient was showing signs of maybe like developing lupus, and it's not something that I could really pick up on because I know the disease state, but I don't know it like as well as the doctors who've actually studied it for several years. Um, so they might be able to see like, oh, well, they're having this symptoms. This might be suggestive of like drug-induced lupus. With Crohn's disease and ulcerative colitis, sometimes you can develop like arthralgias and certain types of arthritis, and there are like specific labs that you can order to test for those things. And so like they would know that stuff and be able to pick up on that a little bit better than I was. And so they might add something like that. Um, versus now I work on a collaborative practice agreement, but it's a lot more detailed. So it says exactly which medications I can order or renew or modify, and which labs I can order, renew, and modify. Where before it was kind of like based on your relationship with the provider. So, like, at my old job, I was also working with hepatology because I was monitoring hepatitis C and hepatitis B. Again, I knew what labs to order for that. So, a lot of times I would just order those labs without asking because I knew we needed to do the hep C viral load at this point and this point. So, okay, but if we need anything additional, it'd be something I would have to ask the provider about or get their opinion about.
I always like talking about collaborative practice agreements for people who want to be more autonomous, being able to have that flexibility, freedom to understand and utilize your knowledge and
Yes.
go ahead and place those orders and those refills. And it also saves the doctor, the nurses a bunch of time as well. We have this ability to do that if we choose to take our license to that level, but also the state that you're in
Yeah.
influences, how likely you are to land in a practice setting that allows you, that even has CPPs as an option, and then the institution that
Yeah.
you're working for can dictate that as well. So, what other skills and responsibilities do you have beyond patient care, beyond your clinical knowledge?
Yeah, so of course you can, or I at my old job, I haven't started doing this yet in my new job, but I would present to like the fellows, the APPs, nurses, residents, learners. I would do a presentation twice a year about the IBD medications and the Hep C medication. Of course, they learn some of that in medical school, but like I would say I can get a little bit more detailed and speak about the side effects. And I would like even include screenshots of how to order the medication correctly. Give them clinical pearls about like drug interactions and like comparing the like immunosuppression of the different medications and that type of thing. Um, at this new job, there's of course precepting opportunities, which I think is something available at most jobs. You can be on committees like a P&T committee or a medication safety committee. Um, they also have projects like each institution may have like a strategic project they want to attain. And so you
Mhm.
can work on those projects with whoever's the team leader to ensure that that happens. Like, I think one of the things they were doing at my current institution is kind of like improving the multi-specialty training system, or like, not training, when we're writing notes to make it more succinct and efficient. So like they reach out to the MSPs, which is what we call the multi-specialty pharmacists. What smart notes or smart phrases do we use? Do we like when we're working up patients, do we work it up the night before? Do we work it up the day before? Do you work it up in the 5 minutes before you see the patient? And if you do, like what all are you doing in your workup? Are you kind of like pre-ordering meds, which is like you put the med orders in, but you don't sign it? Are you pre-ordering labs, that type of stuff, just to help make it efficient, and improve the flow of work or workflow, I guess is the right word.
Thank you. I like to poke around and see what other things people can do. I like the idea of being able to join committees in the health
Hmm.
system that you work in. Some roles you just automatically, you're participating,
Yeah.
and then others you have the option to do so. I would like to ask you about like if there's a glass ceiling for gastroenterology, because as you shared there, you haven't seen them, at least personally, in the hospital setting. You're usually seeing them more in the outpatient focus. Are there other opportunities to still keep your focus, your specialty, your niche, but maybe you don't want to work in the clinic anymore? Like, where
Mhm.
else can you take this knowledge?
I think specialty pharmacies like Credo and like CVS specialties, they will have like pharmacists. And it might not be like GI specific, it might be more like immunology, where they will have to like touch base with the patients that have XYZ disease states or on XYZ meds to make sure like things are safe, to make sure the PAs are done, that type of stuff. Labs are up to date, start dates, that type of thing. So that's one area you can do where it's not as patient care heavy and a little bit more like operational or retail focused, but it is still like GI specific and not like doing primary care, or you're not doing HIV, or you're not doing like COPD meds or something.
Yeah.
And then of course, academia is an option. I think because biologics are becoming a lot more of a big thing and a lot of money is being put into development of biologics. Of course, the companies are making drugs specific for these disease states. So like you have certain companies that will focus on like Crohn's disease or ulcerative colitis, or maybe not specifically those two, but like immunology in general. So like it may be focusing on dermatology, rheumatology, and gastroenterology. And so they'll be producing a lot of drugs focused on those disease states. So if you kind of want to remove yourself from patient care, make more money, um, pharma is an option.
What is that? Oh, that's hilarious. No, but pharma is where that's where the money's at. To your point, I know that medical science liaisons, they have
Mm-hmm.
a easier time breaking into the industry when they're coming from a specialty.
Mm-hmm.
And shameless plug that we have a medical science liaison episode. So you know you want to watch that if you're curious about the medical science liaison industry. But anywho, back to the regular program for today. So we talked about the the ambulatory care BCACP,
Mm-hmm.
which is for ambulatory care.
Yes.
Okay, and mine was pharmacotherapy,
Mm-hmm.
BCPS. So you're in a very niche area. Why did you choose that one versus BCPS? Right, like
I chose BCACP because I mean I know like if I'm working in a patient care setting, I want to do ambulatory care. And I felt that was more specific and more targeted towards what I would do in my everyday. Like, if I decide tomorrow I don't want to do GI anymore and I want to go to a different disease state, BCACP will probably have me covered versus BCPS, I think is more general and maybe like a little bit more focused on inpatient related matter. But I
mhm,
didn't take it, so I don't actually know.
it is.
Versus the AM care one is strictly AM care and it's like disease states that I'll most likely see in AM care.
The people who are interviewing you, the people who are looking for candidates, does it make a difference that you have these certifications?
Do you need to be BCACP certified to be a GI or a rheumatology pharmacist? I don't believe so. But do a lot of jobs require it? Yes. Again, you might be doing GI today and decide, I want to switch to another AM care specialty. So if you have a BCACP, I guess it provides some assurance to your employer that, you are well versed in several different AM care specialties, or since you pass the test, you more likely will be successful even if you transition to another specialty. Um, but I don't necessarily think you need it if you want to be a GI pharmacist.
Okay. So it would be at that point a strategic move
Hmm.
to set them up to be more competitive and then also to give them more leverage if they want to move around
Yes.
in their career.
Hmm.
Okay. You've heard it first, folks. Something to think about.
I mean, a lot of jobs are requiring it, especially like the longer you are in as practicing as a pharmacist. Like if I was practicing for 10 years and 10 years in the AM care space those whole time, and I wanted to switch jobs and I didn't have a BCACP versus somebody maybe that's been working 3 years and has a BCACP, I do think that does give them a bit of an edge. It may make a
Mhm.
difference.
Any other tips or tricks that you have for them as far as like strategic moves to get started or to transition?
No, just like that willingness and eagerness to learn something new. It can be daunting to like learn a whole new disease state and a whole new set of drugs. I realize those things, but if you're somebody who's a little bit more open or, you don't even know anything about it, I would say take the chance to learn about it. It is going to be a big thing. I don't know if it's going to be like as big as oncology because cancer is ongoing, but it is going to be like that next big area where like people are going to put a lot of money into developing medications for immunology, and you're going to see a lot more development. I imagine that at some point, whenever we get to technology, we'll probably start doing more personalized medicine where you can test to see, okay, this is the pathway of your inflammation. So we're going to make all these medications for this. But if you are a practicing pharmacist, there's not really any specific way to get into the disease state just outside of like, okay, I've heard about this. This seems interesting. I would like to learn more about it, or I would like to learn the disease state and applying for a job and just showing that you're willing and adaptable. As a student, you can try to, depending on where you're at, you can try to get a rotation as a first or fourth year to do it. A lot of big medical centers do have specialty disease state. No, UNC does. Kansas, obviously. Yale, where I work at, obviously. Vanderbilt has one, University of Florida, institution in Alabama, I want to say. I did a presentation with several other specialty pharmacists. So I know of some people in certain areas, like your big name hospitals will probably have specialty disease states, and you probably can get a rotation in it. Um, Once you finished, school, PGY1, and you want to try to find a PGY2 in AmCare that has a focus in specialty disease states, or it doesn't have to be a PGY2 specialty pharmacy. It can be a PGY2 ambulatory care, but you want to look at the rotation options that you have. So when I was looking at Kansas, I saw they had several different like disease states. I was like, oh, pharmacists can be there. I want to apply there. So you do have to look into those things and what rotations they offer. But if you know you want to do that from the time you graduate residency, try to find a PGY2 that offers those things.
Yeah, that's good. Could somebody just choose to use that same strategy that you shared with PGY2 and just decide to do a PGY1 general ambulatory care that has those experiences available?
I would think so. I guess it would depend on what that PGY1 ambulatory care would focus on. But again, I don't know if anybody's doing that or if they're just offering for the PGY1s and PGY2. So you would definitely just want to check and see if that's an opportunity as a PGY1 AMP care residency.
Well, thank you, Elena. You have shared so much. They have a lot of, practical things to consider, and then also they have a lot of strategy that
Hmm.
they can incorporate into their journey as they're researching what they want to do. I thank you for your time,
Yes.
sister friend. It has been great,
Any,
and I like learning what you do. And now they know that there is a position out there where you can
yes.
be a gastroenterology pharmacist, either in the
Hmm.
clinic, hybrid, or at home. I'm sure many people didn't know that. I didn't know that until you told me that that was an option.
Yeah. They're
So,
making new roles. I mean, if you're somebody who likes to be in person, there's institutions that will have only in-person positions.
mhm. Yeah, so y'all have a lot to think about. I want to thank you guys for tuning in to this episode. If you have questions, you can drop them in the comments. And yeah, we thank you for joining us. Be blessed and stay curious. And we are out. You just watched an episode of Pharmacy Pathways, a podcast created to help current and future pharmacists find their happy place in life. I'm your host, DomThePharmacist, and I interview different pharmacists from various careers, asking them the questions you'll likely need answered in order to know if that particular role aligns with your interests, passions, skill sets, and talents. If there's a specific topic or career you'd like to see featured, you can let me know by filling out the audience feedback survey on my website. And if you'd like to be a guest, there's a guest sign-up form on my website as well. Both of those links are in the episode description. Thank you for watching. Stay blessed and stay curious. I'm out.